A 37 years old right-hand dominant high school teacher and coach of football team comes to the office because he got his finger caught in a football helmet during a drill. He said that he felt a crack, looked down and noticed his long finger on his right hand pointing towards the thumb. He reported taking hold of it and put it back straight and had the team trainer tap it to the index finger. He doesn't have any history of diabetes, mellitus, or vascular disease, and is not on any medications. Physical examination at the tip of all the fingers has good capillary fill and 2-point discrimination, tested by the Weber 2-point discrimination test. The hand and the fingers show no signs of vascular compromise. The fingers are noted to be swollen with no obvious deformity and no open wound. The patient was able to actively flex and extend all the fingers, but felt pain in the little finger between the MCP and the proximal interphalangeal joint, and was limited in his motion. He was sent for radiograph. The differential here would be a fracture of the proximal phalanx. It can be intra-articular, extra-articular, or comminuted, or a tumor of the proximal phalanx. A diagnosis of extra-articular oblique proximal phalanx fracture was made. Many types of phalangeal fractures are seen, and the examining physician must note the resting posture of the injured hand in each case. When the fingers of the hand are flexed, a line should be drawn from the dorsal aspect of the PIP to the fingernail. This line should converge not to a single fixed point, but rather directly to the area of the scaphoid, from the radial artery to the palmaris longus. One of the most common causes of malunion is a malrotation of proximal phalanx fracture, and is diagnosed by physical examination and not X-ray. Proximal phalanx fractures are often obvious, and local swelling along with deformity are easy to identify. Recognition of rotational or malalignment is essential. A complete sensory and motor evaluation should always be done, and integrity of the dermis should be examined. The vascular integrity needs to be documented, and patency of collateral circulation should always be tested and test of the wrist and the digits. Satisfactory physical examination may not be possible without local anesthesia, but the block should be provided only after a careful 2-point discrimination test has been completed. Indication for operative intervention of the proximal phalanx are based on concerns about shortening and or malrotation. Spiral or short oblique fractures are usually more susceptible for instability, and few millimeter of shortening, although acceptable in the metacarpal, is not acceptable in the phalanx. Malrotation is never acceptable, and operative intervention is required for intra-articular fracture, open fractures, fracture with bone loss, or multiple phalangeal fractures that are associated with neurovascular or tendon injury. Extensive soft tissue injury may require stable fixation to allow early mobilization, and skin loss with hand function associated with polytrauma needs operative repair. In that sense, many factors determine the selection of treatment, including fracture location, intra-articular or extra-articular deformity, angulation, rotation, shortening, open or close injury, stage in neurovascular or soft tissue injury, and the nature of the fracture. Additional consideration for operative intervention or internal fixation include the surgeon's skills for fixation device, the patient's ability to work post-operatively with the appropriate plan, and the patient occupation. The operative goal is always to avoid prolonged immobilization because of risk of permanent deformity and stiffness. However, soft tissue damage, infection, and the need for secondary procedure and technique failure can occur when moving the fracture aggressively if fixation is not rigid. Operative fixation must ultimately have a better outcome than non-operative management. The risk and benefit must always be explained to the patient. There is a wide array of different types of non-surgical management, and choice depends on the experience and expertise and personal preference of the physician. Not a single method of treatment can be applied to all fractures, and the surgeon must be comfortable with multiple techniques. Fracture healing takes the same amount of time no matter which method is chosen, if treatment is performed correctly. Many fractures of the phalanx can be treated by close reduction and cast immobilization. If the fracture pattern is stable, that is transverse, it can be treated non-surgically. Fracture pattern that are inherently unstable, like spiral oblique, will fall out of alignment and will usually require surgical stabilization. Soft tissue conditions with any neurovascular compromise or swelling may prevent non-operative treatment. The position of immobilization is the intrinsic plus position, with the MP joint at 7-degree flexion, if not 9-degree, and the PIP and distal interphalangeal joints in extension. A proximal phalanx dorsal blocking cast with the adjacent finger held in cast can be applied when the hand is in intrinsic plus position. Contracture is avoided and intrinsics are maintained in the relaxed position. This position has effectively immobilized stable fractures of the proximal phalanx. Management of soft tissue is paramount to a successful outcome when treating phalangeal fractures. The ideal surgical exposure provides maximal visualization of the surgeon while preserving soft tissue gliding planes and minimizing surgical insult to the surrounding tendons. Exposure of phalangeal for fracture fixation is done primarily from a dorsal or a lateral approach. Palmar exposure is discouraged except when the PIP joint exposure is necessary for a volar plate arthroplasty. Exposure of the proximal and middle phalanx is accomplished through a dorsal, longitudinal incision or a mid-axial incision, with the terminal aspect of the incision curved towards the midline of the digit. The end of the incision are incorporated into the dorsal skin crease, allowing for adequate cosmesis. This extensile exposure allows access to the extensor hood as well as access to the mid-axial line. The extensor tendon must be retracted for exposure of the fracture when access to the middle phalanx is necessary. The periosteum should be incised at the mid-axial line and raised as a flap, thereby preserving the gliding surface between the periosteum and the extensors. The proximal phalanx fracture is exposed through a dorsal longitudinal split in the extensor tendon have adequate exposure. The periosteum should be raised as a flap to allow exposure of the fracture and preservation of gliding surface between the fracture plane and the extensor tendons. In a long-on oblique fracture, open reduction internal fixation can be instituted. Screw fixation is used in the management of long oblique fractures. To manage fracture with screws alone, it is recommended that the length of the fracture be at least 3 times the width of the shaft. The choice of implant depends on the skeletal size and the fracture location. Low-profile implants are widely available now. In general, phalangeal fractures are fixed with 1 or 2 mm screws. Self-tapping screws diminish the technical complexity of the technique. The technique of compression screw is usually done in a reproducible sequence of steps. Once the fracture has been opened, the fracture line is identified. The fracture is anatomically reduced and held in position with a clamp or a small, smooth K-wire. Ideally, the surgeon should try to minimize the exposure of the skeleton, thereby limiting the devascularization. First, drill the near cortex with 1.5 mm drill bit, because this allows the screw to dynamically compress the fracture site. The technical point of this technique is to drill only the near cortex with the larger 1.5 mm drill bit. Then use a countersink to the neocortex to increase the contact pressure of the screw head. Place the drill guide into the neocortex drill hole and then drill the far cortex by 1.1 mm drill bit. The drill sieve is designed to fit in the neocortex and align the drilling of the far cortex. Measure the depth of the hole on the volar aspect to get the correct length and then tap with a 1.5 mm tap. Using a tap sleeve protection, the surrounding soft tissues, place an appropriate screw and follow with the second screw, and if necessary a third screw should be placed accordingly. In case of transverse fractures, intraosseous wiring may be needed. The surgeon may choose to from wrist blocks or IV regional or brachial block or general anesthesia. Using a dorsal longitudinal incision over the long proximal phalanx, we make a lateral approach. We elevate the periosteum and preserve it for later closure. The fracture site is exposed and the fracture hematoma is debrided. The clean two fracture ends are exposed and the drill hole is made with a 0.035 inch K wire, parallel to the transverse fractures, leaving a bridge of at least 5 mm from the fracture line. A 26 gauge stainless steel wire is then passed through the hole, keeping in mind that the side you want to leave the twisted wire is on the side you start on. This is usually best when left on the non-contact sides. Load a smooth 0.035 inch K wire into your driver and place it obliquely out through the dorsal cortex until the tip protrudes slightly at the fracture site. Now, reduce the fracture anatomically and then advance the wire into the proximal phalanx and achieve cortical contact. The wires are now then twisted around each other and using the appropriate device are tightened. Secure the loop into the bone. The twisted ends is bent so that it's not prominent and to avoid soft tissue irritation. The periosteum is then restored and closed, following by simple closure of the skin. The K wire remains in place and is trimmed to the appropriate length and the tip protector is attached. Alternate technique can be a plate fixation. Plate fixation in hand surgeons should be infrequent and should be reserved primarily for metacarpals. Use of the plates in the fingers is discouraged because of the frequent need for removal of hardware and tenolysis. However, higher comminuted fractures may require fixation with plates to allow adequate stability for early motion. For the phalanx, 1.5 and 2 mm plates are recommended. Their application and extensive exposure of the joint and needs precise placement of the implants. When you talk about the complications, loss of motion is the most common and frequent complication and needs a lot of workout. Infection is one other risk. And flexor and extensor tendon adhesions is possibility.